Good morning, everyone. Welcome to the new series of Oncology for Non-Oncologists. The video intended for the enthusiasts in oncology who are still non-oncologists to explore the world of oncology. The series is mostly derived from Robin's textbook of pathology, written by Vinay, edited by Vinay. He's a very great author. I happened to meet him once. I don't think he can remember me, but I do adore him. It is a wonderfully written book where the entire glimpse of oncology can be given to you within a 70 pages. And in fact, it's a great achievement. Before beginning to what oncology is, let us name it. Naming has been a tradition and an upliftment of human civilization because when you name it, you will know it. So let us start with the first thing called nomenclature in oncology. So the first thing that we need to know is definition. Oncology, also called as neoplasia. Let us define neoplasia before going to learn what oncology in toto. So neoplasia is a genetic disorder of uncontrolled cell growth that is triggered by mutations and it is not controlled by physiology. This simple definition will give you a glimpse of what all happening in oncology right now in a broad way. The first place, neoplasia, which is a new growth. Neo is new, plasia is growth. It is a genetic disorder, which means that the problem in cancer doesn't lie at the level of system, tissues, cells. It lies at the place of genes. And that not to a single gene, but rather than many genes that are mutated over a period of a time, which act together and increase the proliferation capacity of the cancer. That is been explained in the next term, uncontrolled cell growth. What do you mean by uncontrolled cell growth? Cell growth usually happens in our body. Our mucosa regenerates every day. Our hair falls and comes back, which is a type of cell growth. Babies get born, which is a type of cell growth. Sometimes uterus gets enlarged, it's a type of cell growth. But neoplasia is not any kind of cell growth. Neoplasia is that kind of cell growth which is not controlled by normal physiology. That amalgamates or accumulates the main concepts of neoplasia and that defines cancers in toto. So let us see, once you understood about neoplasia, let us see what are the components of neoplasia. When you read a pathology report or anything, you see different kind of things. So they describe two things. The first thing, they describe the cells. How are the cells? So the cells are called the parenchyma. It is made up of transformed neoplastic cells that form the tumor bulk. Along with the parenchyma, there is also stoma that is inherent to that particular tissue, and it is made up of connective tissue, blood vessels, and cells of innate and adaptive immune systems. Every component of this word is being further elaborated in the next few chapters. So if you, the description of the picture, if you see the cells are okay, we are going to discuss about things, but the stoma, if you observe carefully, we have the immune infiltrates. The immune infiltrates, which consists of macrophages, T lymphocytes, regulated T lymphocytes, each has its own role. And we have fibroblasts, which form the tumor. And we also have dendritic cells, which present the antigens. We have pericytes, which surround the blood vessels that are present in the tumor. And we have lymphatic vessels and blood vessels. All together contribute for the growth of cancer cells in many different ways, which we are going to discuss in the further things. Let us start our discussion first with the parenchymal cells. So we'll discuss about the parenchymal cells. These parenchymal cells are benign or malignant. Further chapters are mostly on malignant cells because benign cells are not harmful. Why they are not harmful? They do not have the capacity to grow and in an uncontrolled way. However, differentiating benign and malignant is one of the fundamental duties of an oncologist or a pathologist because it changes how we pursue or how we view the cancer. Benign is like a local disease. Malignancy is not a local disease, but it is something deal with the systematic disease because malignant cells acquire such a capability that a simple surgery cannot remove the cells totally. So Let us name benign tumors. So we start with benign tumors. Benign tumors are usually named omas. Based upon the origin of the cells, they are again divided. Mesenchymal cells, for example, are called fibromas, the cells that derive from fibroblasts, and chondromas, the cells that derive from cartilaginous cells. In epithelial cells, however, we name it in a different way. Based upon cell origin, we call them adenomas. Based on appearance, we call them cystadenoma and polyps. So benign epithelial cells, how we name it based upon cell origin. Let us just quote the term adenoma. Adenoma means a benign cells. They are the most common. We have just described two different type of adenomas that arise from the same renal cell. So the other part describes from where it is emerging. So renal adenomas emerge from renal tubular cells. Renal cortical adenoma emerge from renal cortical cells. These are the microphotographs of renal adenoma and renal cortical adenoma. Renal adenoma is a benign neoplasm that arises from renal tubular cells and forms tightly clustered glands, while adrenal cortical adenoma comes from the cortical cells of the cortical cells, and they are called as cortical adenomas. Based upon microscope appearance, sometimes we see something called papillomas. What are papillomas? They are finger-like or warty projections from the epithelial surfaces. Then we have cystadenoma and papillary cystadenoma. Cystadenoma is nothing but formation of a cyst. Because it is looking cystic, we call it as cystadenoma. And something called an papillary cystadenoma, where we'll have papillas within the cyst, so we call it as papillary cystadenoma. And sometimes most of these cells are derived from single germ layers. Sometimes a benign tumor contains of different kind of cells. When these different kind of cells can be derived from a single germ cell layer, or it can be derived from multiple germ cell layers. Examples for single germ cell layer, a benign mixed tumor where all the cells come from single germ layer. We need to be very clear. It is a single germ cell tumor which contains of different cells. It is a benign tumor which consists of different cells, but all these cells come from single germ cell layer. And sometimes the same cells come from different germ cell layer. Examples are, let us take an example of pleomorphic adenoma. Pleomorphic adenoma is a benign tumor of the parotid gland. In this pleomorphic adenoma, we find different kind of tumors, which is very different from other adenomas where all the cells look alike. So in pleomorphic adenoma, there will be different kind of cells. So these cells may be bone cells, maybe cartilage cells, some epithelial cells, but all these cells are derived from single germ layers. If you remember, germ layers are three: ectoderm, endoderm, and mesoderm. Then comes to a different kind of benign tumor called dermoid cyst. Dermoid cyst is also a benign tumor, but the cells within the dermoid cyst are derived from different germ cell layers. So there are different cells derived from different germ cell layers. It is, example is dermoid cyst. Different cells derived from single germ layer, it is called pleomorphic adenoma. So what all different kind of things can be seen in a dermoid cyst? I'll just give an example. Look at this example. The single dermoid cyst will contain of a tooth, which is very rare, and it looks clumsy. You get irritated. It has hair, it has tooth, and it has also some sebaceous gland, so it appears sticky. So this is an example of dermoid cyst. Look at pleomorphic adenoma. Pleomorphic adenoma also contain different kind of cells, but all these cells are different kind of cells, but all these cells are derived from single layer. In pleomorphic adenoma, they are mesenchymal cells. So mesenchyma gives rise to epithelium, they give bone, they give to cartilage. So this is the naming of benign tumors. Now come to malignant tumors, the crux. The most important thing of the topic is malignant tumors. Malignant tumors are otherwise called cancer. Why they are called cancer? Cancer is a Latin word which means crab. So why did we call them as cancer? Because these tumors, based upon their appearance, macroscopic appearance, based upon surgeons could easily remove a benign tumor because it was encapsulated. It was easy, but they couldn't remove any kind of malignant tumors. You know why? These tumors adhere to the surface so tightly that it is very difficult to remove. And what is another thing which adheres so tightly? It's a crab. Crab adheres to a surface so tightly that we can't remove it so easily. So the reason why we use Latin terms, because the people used to fight which country is greater, French, British, German, Italian. So how they should be named. So they came to a conclusion that let us not fight in between us. Let us name the things, name scientific terms in a language which is not, it doesn't belong to any country. So they decided on Latin. Latin was a language spoken in ancient time by people of Rome, in fact, the entire Europe. So, and all European languages have their ancestry to Latin. So it's not controversial. It's a middle term. So cancer is a Latin term from crab. They named it cancer in Latin because they never fight based on which language is greater, so that it is named properly. Now, how will we name malignant tumors? Malignant tumors are again divided into, as like benign tumors. Malignant tumors can be derived from single parenchymal layer, or there can be different parenchymal cells. These different parenchymal cells again can be derived from single layer or multiple layers. Let us go ahead and say. So mesenchymal tumor, we'll start with mesenchymal tumors. Mesenchymal cells mesenchymal cells can generate into bone, they generate into adipose tissue, they develop into muscle, nerve, myocardium, liver, trachea, and skin. These are all the organs that are derived from mesenchymal cells. So let us go into. So connective tissues, blood vessels, blood cells and related subtypes, and muscle. So different kind of mesenchymal cells are there. So if it is a fibroblast, the benign tumor is fibroma, as we discussed earlier. The malignant tumor we use called sarcoma. Sarcoma means it is a malignant tumor that is derived from mesenchymal cells. Lipocyte, it is lipoma, and malignant tumors is liposarcoma. The chondrocytes, it is chondroma, and the malignant tumor is chondrosarcoma. Osteocyte, the benign tumor is osteoma, the malignant tumor is osteosarcoma. These are the cell of origins of different kind of cancers that are present here. So then we also have blood vessels. So blood vessels, benign tumors is hemangioma, whereas the malignant is hemangiosarcoma. Lymph vessels, it is lymphangioma. Malignant tumor is something named as lymphangiosarcoma. Mesothelium, the benign thing is benign fibrous tumor, and the malignant tumor is something called mesothelioma. Brain coverings, usually they are called meningiomas. Meningiomas are, in fact, meningiomas are graded as WHO 1, 2, and 3. And the third is the most invasive. We call it as invasive meningioma. If you observe very carefully, the sarcoma term, though derived from mesenchyma, is not present in mesothelioma and invasive meningioma. These are aberrant things that you need to remember. So what are the cells that are derived from the blood vessels? So sometimes blood cells or the hematopoietic cells, white blood cells, will have a leukemia reaction, whereas there is increase in the WBC cells. But what is the characteristic? They are polyclonal. They are different kind of molecules present on different kind of cells. But a counterpart of this one is leukemia, where a single cell, it is monoclonal, and they proliferate so much and they generate into something called leukemia. Lymphoid cells, the benign tumor is called lymphadenitis, that usually occurs during infection due to antigen recognition and proliferation of the cells in the lymph node. The same thing happens when there is a clonal, when there is a clonal proliferation, it is called lymphoma. And the tumors derived from muscle, there are smooth muscles and striated muscles. Smooth muscle, the benign tumor is called leiomyoma, and the malignant tumor is called leiomyosarcoma. And the striated muscle, the benign tumor is rhabdomyoma, and the malignant tumor is called rhabdomyosarcoma. So then we have the most common cancers called carcinomas. Carcinomas are nothing but epithelial tumors, malignant tumors of the epithelium. Where do we find epithelium and where is it is derived from? Epithelium can come from ectoderm, endoderm, or mesoderm. It can come from any layer. What is the function of epithelium? It forms a covering, and sometimes it secretes substances which are useful in other substances. So they are usually divided into squamous cell carcinoma or adenocarcinoma. So squamous cell carcinoma has squamous epithelium, and adenocarcinoma grow in glandular pattern. So epithelial tumors origin, they can come from stratified squamous cells, they can come from basal cells of skin or adnexa, they can come from melanocytes, which is called as melanoma. They can come from epithelial lining of glands and ducts like salivary glands. Adenocystic carcinoma. They can come from respiratory passages like in case of bronchogenic carcinoma. They can come from renal epithelium, which is a renal cell carcinoma. Urinary tract epithelium, especially transitional epithelium, which is called bladder cancer. Placental epithelium, with gestational trophoblastic tumor. Testicular epithelium, usually seminomas and non-seminomatous germ cell tumors. So stratified squamous epithelium, see the benign tumor counterpart is squamous papilloma, while as the malignant counterpart is squamous cell carcinoma. So you see the papilloma, that was, they are finger-like warty projections extending from the core. They have a fibrovascular core and the squamous cells. They are uncontrolled proliferations, but there is growth, but they are still under control. So this is squamous papilloma. This is squamous cell carcinoma. The basal cells of skin are adnexa. There are no benign counterparts for that one, but the malignant, the basal cells is basal cell carcinoma. Melanocytes, it's a benign nevus. Malignant, it is called malignant melanoma. If you see here, underneath the epidermis, we have melanocytes. These melanocytes will transform. If they are benign transformation, they are called nevus. If they are malignant transformation, they are called malignant melanoma. So epithelial lining of the ducts, if it is adenoma, it's adenocarcinoma, papilloma, papillary carcinoma, cystadenoma, cystadenocarcinoma. Respiratory passages, if we see, it's bronchial adenoma and bronchogenic carcinoma. Renal epithelium, benign, as we discussed earlier, it is renal tubular adenoma. The malignant, it is renal cell carcinoma. Where do renal cell carcinomas comes from? They come from epithelial cells, which are usually present in the nephron. They proliferate and cause this kind of cancer. The liver cell, the benign liver cell is called hepatic adenoma, whereas the malignant is called hepatocellular carcinoma. Urinary tract epithelium, benign is called transitional cell papilloma, malignant it is called transitional cell carcinoma. This is an example. It's a flat tumor. This is a papillary tumor coming from the transitional cell epithelium of the bladder. This is a pictorial representation of the disease. A small thing is, this is the muscle. So the treatment basically derives from whether it is muscle invasive or non-muscle invasive. Until it is non-muscle invasive, usually the patients are in a curable position. Placental epithelium, benign, it is called hydatiform mole. Malignant, it is called choriocarcinoma. So hydatiform mole, this is a grape-like appearance that is present within the uterus. So choriocarcinoma is characterized by invasiveness. It comes from the placental epithelium. So again, the moles are divided into complete mole and partial mole. Complete mole, there is no paternal DNA. Usually two sperms get the two sets of chromosomes of two sperms without a maternal DNA will just conjugate with egg and form 46XX or 46XY, where only paternal chromosomes are there. This is called the complete mole. Partial mole, there are two sperms, one of the two sperms, and there is also egg. So there will be three sets of chromosomes, 69XXY or 69XXX. These cause a triploid architecture, which can be called as partial mole. So the spectrum of gestational trophoblastic tumor, this is the complete hydatiform mole. So it doesn't have any maternal chromosomes, it has only paternal chromosomes, so it androgenetic mole. And partial hydatiform mole, where it has three sets of chromosome, and this is the scenario that happens. And sometimes the partial hydatiform form, there can be a live fetus, which is exemplified here. And there are invasive moles, there are choriocarcinoma and placental side trophoblastic tumor. Testicular tumors, we have seminomas and embryonal carcinomas. The benign components, and there are no benign components for that one, but the malignant components are seminoma or embryonal carcinoma. This is an example of where the testicular tumors comes. Usually the testicular epithelium, we get seminomas or not. Usually they are called as non-seminomatous tumor. Non-seminomatous tumors are different kind of things. They are embryonal carcinoma, yolk sac carcinoma, choriocarcinomas, and all those things. These are the cell cancers that are derived from the testis. And there are again undifferentiated tumors. We don't find any counter. We can't differentiate them. We can't just say this is coming from different this type of cancers. They are named separately. So, and there are mixed tumors where there are different kind of these are malignant, but there are different kind of cells that are present in the tumor. These cells can be derived from single germ cell layer, or they can be derived from multiple germ cells. Example for the mixed but derived from single layer, we discussed earlier, salivary glands. It's the benign is pleomorphic adenoma, while the malignant is malignant mixed tumor of salivary glands. Similarly, from the renal cell carcinoma, Wilms tumor contains cells of different kind of cells derived from same germ layer, but it contains different kind of cells. It's a renal enlarged. It's a precursor of kidney. So Wilms tumor and nephroblastoma, it has metanephric blastemic cells which are responsible for kidney development. It has different components, as we see here. There are small round blue components, which is blastemal component. There are epithelial components and also mesenchymal components. Then there are mixed tumors. These in mixed tumors with different kind of germ cells contributing to them. Among there are totipotental cells of gonads or in embryonic case. The benign cells are called mature teratoma or dermoid. The malignant cells are immature teratoma, teratocarcinoma. So these are differences between teratoma and teratocarcinoma. Teratoma are mature cells, teratocarcinoma are immature cells. Teratoma are differentiated cells and tissues. Teratocarcinoma are undifferentiated epithelial cells, which are pluripotent, highly proliferative, and able to metastasize. Where teratoma, they are benign, and teratocarcinoma are malignant. So this is an example of teratoma. It simply says that these cells will have different kind of cells that are derived from different kind of germ layers. It's a astonishing picture where we have tooth from the hand, which is not inherent to that thing, but because the germ cell layer can produce any kind of cell in the body, this kind of things happen. So nomenclature, we have till now we have named the parenchymal cells. We should also name the stoma. In cancer, along with the parenchymal cells, stoma is also modified. How we name stoma? We'll see in the next slides. So cancer stoma is not a static organ. It's not simply a place where it grows. In fact, recent discoveries have told that it contributes to cancer as much as the parenchymal cells. It is responsible for the immune escape. It secretes certain substances both to inhibit or proliferate the cancer. So the stoma usually contains of tumor cells. It consists of fibroblasts. It consists of pericytes. It also consists of blood vesiculatures. So there is usually a term that is used in cancer reports, desmoplasia. What is desmoplasia is because the parenchymal cells stimulate the formation of abundant collagenous stroma. This abundance of collagenous stroma is called desmoplasia. Some desmoplastic tumors, like example is a skirrus, is some cancers of the female breast. They are stony hard or skirrus. Skirrus nothing but it is desmoplastic. Collagen contributes to the hardness of the tumor. This is an example of a skirrus carcinoma of breast. If you see here, the normal counterpart, stoma, as cell, the texture of the tumor is determined by the stoma, not the cells. So how the stoma is, that determines how the tumor, whether it is soft, whether it is fibrous, whether it is like hard, it is determined by the stoma of the tumor. If you see here, just look into all the other things that are present here and look into the tumor. Tumor appears hard. It is because this has some kind of desmoplastic reaction. The stoma has secreted more collagen. Because of the secretion of more collagen, it appears stony hard, and in sometimes it is called stony hard, called skirrus. And there are again some miscellaneous terms that we use. They are called hematomas. Hematomas are disorganized masses composed of cells indigenous to involved tissues. They are once thought to be developmental malformations unworthy of OMA designation, but they are found to have certain kind of clonal chromosomal aberrations right now. Then there is something called choriostoma. They are misplaced rest of the cells. For example, a small nodule of well-developed, normally organized pancreatic tissue can be present in stomach or small intestine. So these are some miscellaneous terms. They appear to be cancers, but they are not totally cancers. The two terms, hematoma and choriostoma. So this is an example of hematoma, wherein a disorganized mass is composed of cells indigenous to the involved tissue. It is normal spleen. These cells are usually present in the spleen, but they are organized in a different way. And the same thing happens in the eye. So just end with the quotation. Why should we know the names? Because however we name the tumor, it behaves in its own way. But name is a term. Name is a method where we can communicate about that particular cancer to a different person. And knowing the names of different kind of cancers helps us in understanding the pathology reports and different kinds of cancer terminology that we usually hear. Thank you. And let's wait for the next session of oncology for non-oncologists. Thank you very much.